Hello everyone, welcome to Physio Lectures. So today I'm going to discuss regarding the respiratory assessment. So previously we basically used A-to-E assessment method, but now these days we are using A-to-I respiratory assessment method. So I'm going through each like from A to I one by one. So first of all, in a respiratory assessment, we are going to see the A. So basically A, in A to I assessment, A stands for airway. So when we go to see the patients, what's the important to know? How is the airway? Is the patient got their own airway, or is there any ETT, endotracheal tube, or so what's the mode of ventilation? That's the first thing we are going to check. Or is there any tracheostomy tube? Now if we check the airway, it is important to know how is the airway. Is the airway open? Is there any obstruction in airway? Is that the partial or complete obstruction? If there is complete obstruction, then it's definitely emergency, and we need to, that's a kind of like emergency situation. So first of all, we check the airway. Patient is got their own airway or any ETT tube or tracheostomy, we mentioned that in our notes. And then how's the like, is the airway patent or any kind of obstruction? Then we next go to the B, so which is breathing. So in breathing section, that's the main section and part of our like assessment for breathing. So first of all, we need to see what the SpO2 level of the patient, what the oxygen sets are. So is it above 94 or it's between 88 to 92? And we also check the like target sets of the patient. Like sometimes patients are on scale 1 and sometimes are on scale 2. If it's on scale 1, then target sets are always at 94 and above that. But sometimes patient got long term COPD conditions and some like other lung condition which can compromises the lung, and patient might be on a scale 2, which is always signed by a consultant, like whether a patient is on scale 1 or 2, and we can find it on a like regular news chart and in the medical notes as well. And for scale 2 patients, the target sets are between 88 to 92 percentage. So once we check the sets of the patient, then we need to check the oxygen. Is the patient is on like ventilating on room air or any additional oxygen requirement? If yes, then what's the method of delivery and how many liters of oxygen? For example, for 1 to 4 liter or maximum 5 liter of oxygen, patient is usually on nasal cannula. And then the patient, if more oxygen requirement, then it's on the venturi mask. And we need to check, is it humidified circuit or the dry circuit? So sets, then oxygen, how many liters, or the patient is on room air. If patient is on oxygen, then how many liters of oxygen and method of delivery. So mention that, for example, we can mention that SpO2 is equal to 98% on room air. Or for example, we can also take an example, 98% on 1 liter of oxygen via nasal cannula. So we can mention in that way. Second is respiratory rate. So we can see like, is the patient got any respiratory higher or lower respiratory rate? So always mention like, the second thing is to check the like respiratory rate of the patient. Next is any use of any sign of respiratory distress, like is the patient using any accessory respiratory muscles? How is the like patient breathing? Is patient breathing through the mouth or through the nose? Is patient using any accessory respiratory muscles like sternocleidomastoid or levator scapulae, any like? So we can mention that as well. For example, if patient is not in any kind of distress and not using any respiratory like accessory respiratory muscles, then we can also always mention like there is no sign of respiratory distress or no use of accessory respiratory muscles. Next is a part of assessment for breathing is auscultation. So always first start from the upper to lower zone, check on both sides. Is there, how is the air entry, is there any reduced air entry or base breath sound present throughout both sides, any additional breath sounds like crackles, wheeze, which can give us a like indication of like ongoing some medical conditions as well. So it's important to know like auscultation, how is the air entry throughout the lungs both sides, and is there any additional sounds. Next is palpation. So palpating the chest, first it is important how is the chest expansion, bilateral, same, is one side, for example left side is like reduced chest expansion compared to the right side, so we need to check the chest expansion. Then any like tactile phreatitis on palpation, if yes then it might indicate any kind of secretions. Then when we are checking the like chest expansion, and we can also check the temperature like any hot and cold, compare the central and periphery, it's also come under the palpation, like the palpation any hot or cold extremities, maybe periphery are cold and the compared to the central part, which indicate might be blood supply is poor on the periphery. So this we can assess under palpation. Next is the most important is the cough. How is the cough strength? Is the patient got a good cough strength? Is it moderate cough strength or weak cough strength? And if patient got a cough, is it wet or dry cough, or it sounds wet, or if it's like wet, is it like productive, patient able to bring out secretions, or patient find difficulty with like bringing out secretions? And is the cough present spontaneously or on command, is patient is coughing on command given by the therapist, or patient coughing by their own? So it is important to mention all this stuff in a cough part. For example, if patient got a good strength of cough, productive, wet and present on command or spontaneously, that means patient is coughing and clearing the secretion. But if the strength is like moderate, there is a dry or maybe wet cough, but patient find difficulty with expectorating out, then we need to that include in our problem list, and then we need to work on that as a part of our treatment. So it is important. Then next is the what the ABG values, what's the like pH score, is it patient acidotic or alkalotic, or patient pH is normal, which is 7.35 to 7.45. What's the oxygen, is that like patient is hypoxic or hyperoxemia. So normal value is between 11 to 14 with it, so it changes according to unit as well. And then the carbon dioxide, same, base excess and bicarbonate. Actually ABG value is a good to determine like is patient like more related with metabolic symptoms, or it's more respiratory symptoms, is it acidotic, alkalotic, type 1, type 2. So we can find a lot of things from the ABG's value. Next is definitely chest x-rays, and it's always important, if we got the like previous x-rays as well, compare the previous chest x-ray with the recent one, which give the idea is it worsening or situation is worsening or getting better. And any respiratory related medication, like for example if patient is on any bronchodilator, might be on any saline nabs, then we need to mention that, or maybe on any mucolytic agent which is helping to break down the secretions. So mention all this in a B part. So in A we did the how is the like airway, then in breathing B we check the SpO2, oxygen level, respiratory rate, any signs of respiratory distress, auscultation, palpation, cough, ABG, chest x-ray and respiratory related medication. So it give a lot of idea regarding any respiratory related symptoms. Then the C stands for circulation. So first of all, important to know the heart rate. Like usually it's normal is between 60 to 100 beats per minute for adult, but if it's less then bradycardic, if it's more than tachycardic. So we need to know about what's the normal for the patient. BP usually 90 over 60 to 140 over 90. So it's important to check the trend for a person. Like few person it's always into the higher side, and for few adults it always into the lower side. So we need to know the like what's the normal limit range of the patient for the patient. Any skin discoloration, like any central or peripheral skin discoloration, so that's important. Capillary refill time, which also give us an idea regarding any circulation related issue. BM for healthy targets, like before meal sugar targets, it's usually 4 to 7 millimole per liter, but if it's high and low we need to consider that as well. Any temperature changes for like BNP, usually less than 100 picogram per milliliter, it's okay, but if it's going over 100 picogram per milliliter, then it's maybe a sign of heart failure, and then medical team to assess patient further. So that's also important to check, like on admission, if there any BNP like level checked for the patient, is there any previous history of heart related issue. Troponin level normal range is 0 to 0.04 nanogram per liter, but higher than that might indicates like heart attack. So for like usually those who come with the heart attack or like heart related conditions, so check the troponin BNP as well. So in circulation it is important to check the heart rate, blood pressure, skin color, capillary refill time, then before meal sugar, then temperature, BNP, troponin. Then D is disability. So basically we can find it in different ways. So first of all, the first method is to check the GCS score, Glasgow Coma Scale. If it is 15 out of 15, then patient is mean alert, awake, oriented. So GCS can be lowered down to 3 when patient is unresponsive, unconscious. So GCS score, apart from that we can say the level of consciousness, like is the patient alert, is patient responding to voice, is patient is responding to pain, or it's unresponsive. So level of consciousness is important. In ITU especially, where the patients are sedated, so they consider the RAS score. Usually it's like 0, -1, -2, and also like in plus as well. If patients start like agitated, then +1, +2. So RAS score. And if patient is sedated, then which medications are used for the sedation in ITU? Most commonly used like sedative medications are fentanyl and propofol, but it's worth it to mention that in our notes. So that is like disability. Now next is E, which is exposure. So when we are going to assess patient, always patient got some like additional attachments most of time. So this additional like attachment can be a urinary catheter, any kind of drain, any stoma bag, IV cannula, NG tube, arterial line. We need to mention that in our documentation as well. But apart from that, it is important while we are trying to do the transfer or mobilize patient, then we need to take proper consideration of these attachments. So we don't want to like make anything worse, so it is better how to manage that. So for example, if it's a drain, then it's worth it to mention it is swinging, bubbling, and so apart from that, the position of the patient is important. Like when you went to see patient, what is the position of the patient? Is patient supine lying on the bed, is in high upright sitting on the bed, or maybe patient sitting on a chair? So it's worth it to mention, like when you went to see patient, what's the position of the patient and which are the attachments. So if there is like any kind of leakage from stoma bag, or you notice any kind of bubbling in drain, so it is worth it to mention to the nursing staff so they can look over that. So that's A to I. Now next we go to the F. F is fluid balance. So basically input and output balance, fluid balance of a patient. So if it's positive, like in last 4 hours, if it's positive, that means patient is retaining fluid. So in case of heart failure or heart related issue where patient can, then it can lead to the edema, like patient is retaining fluid, and that's why some patients you saw they are in on like 1.5 liter or might be 1 liter fluid restriction, as the medical team are checking over their fluid balance, as they need to maintain the balance. When we are checking the fluid balance, we need to assess what's in the last 24 hours, what's the yesterday fluid balance, what's the today fluid balance, is it negative or positive, and also check the urinary output in last 3 hours, like is there any retention of urine. Sometimes the retention of urine can lead to the delirium and confusion, all those things. So it is better to check the urine output in last 3 hours, and fluid balance, compare yesterday's and today's as well. Is patient retaining the fluid or not? Is the negative balance or the positive balance? What's the target set by the medical team? That's also important. So that's come under the F. Next is G. G related to gastric. So it is also important to look over the diet chart. So is the patient is on normal diet or eating and drinking well, or on any liquid diet, or any recommendation by salt team, as sometimes if the patient is on liquid diet and have swallowing issue, and sometimes they eat like maybe they are not under salt speech and language therapist review, and they might eat the solid food, then it might cause the aspiration pneumonia. So we need to consider that what the level of diet patient on, is there any special diet recommendation for the patient, or if patient is on NG feed, then we need to consider like is the patient is nil by mouth or on NG feed. Now H is hematology. So hematology, first check hemoglobin of the patient. So low hemoglobin is contraindication to the therapy. So normal adult male hemoglobin range is 130 to 180 gram per liter, and normal adult female is 115 to 165 gram per liter. So we gave the therapy, but if it's below 90, then we need to consider it the medical advice. It's like contraindicated for therapy sometimes, but we should, like if it's low hemoglobin, we should check for the symptoms, everything. Platelet count next. So platelet count is for normal adult is 140 to 400, but if it's very low platelet count, then it is contraindications. There are some contraindication. For example, we need to check if we can do the suctioning or not, like suctioning can cause the micro trauma, and if platelet is already low, then there will be issue in the clotting of the blood. So it's better to consider the medical advice if the platelet is too low, and to outweigh the benefits and the harms of suctioning. So that's important. Then also check the urea and creatinine level. If it's high, then might indicates kidney injury. Sodium level, usually it's between 135 to 145 milli equivalent per liter. If sodium is low, then it is known as hyponatremia. So in hyponatremia, it can cause symptoms like nausea, vomiting, loss of energy, confusion. Serious hyponatremia, when it's too severely low, then it can cause seizure, coma, and even death. Usually we saw in older people, they usually sometimes came with hyponatremia. If sodium is high, then it is known as hypernatremia. Then it can cause thirst, then lead to confusion, muscle twitching, seizure, coma, and sometimes lead to death as well. So that's why sodium level is important. Then potassium level, which is between 3.5 to 5.2 millimole per liter. So if low potassium, which indicates heart problems such as an irregular heartbeat. High potassium is also dangerous and need immediate treatment as it can reduce the muscle activity. So always, for like potassium is more related to heart, so it's always to consider like to check the potassium value. So sodium, potassium, then albumin, 3.4 to 5.4 gram per deciliter. So in hematology we check hemoglobin, platelet, urea, creatinine, sodium, potassium, albumin. Then next is I is like infection markers. So first infection marker is like CRP, C-reactive protein, CRP. If it's less than usually it's less than 0.3 mg per deciliter, but if start increasing, it indicates like the presence of any infection. So if it start raising, then we need to check like is there any infection. Check WBC and neutrophil also. If there is increase in level of like CRP, WBC, neutrophil, then it indicates the presence of infection. So always check the inflammatory markers. So that's the A-I assessment. A is airway, B is breathing, C is circulation, D is disability, E is exposure, F is fluid, G is gastric related, H is hematology, and I is the infection marker. So before going to see the chest patient, it is important to know, is the patient more related to circulatory issue, more respiratory issue, what's the blood showing, is there any contraindication to the therapy, what's the infection markers are in. So A-I in assessment give us a complete idea. So that's all about our respiratory assessment. Thank you for listening. If you like these kind of more videos, please like and subscribe the channel, and also you can give us an idea regarding few more topics on which I can make more videos in the comment section. Thank you.